Dr. Taylor Martin, a lot of times when I get my lab work done, I'll have like these numbers that are sometimes way out of reference range, like big, bold font, on my lab test. And I've seen it enough times to know that like, okay, I can navigate this, but a lot of times like you get these like high creatinine levels or high creatine kinase levels. We talk about a number of them, like crazy high numbers. And the physician's just like, okay, well, this is an outlier. This is a problem. But a lot of times there's perfectly good explanation for these like really wild out of range numbers. And I wanted to talk about kind of the more common ones, but let's open with creatinine because people say, I have high creatinine, my kidneys are failing. But not always the case.
Certainly, you're right. It's not always the case. And that's one of the issues with using these reference ranges for the general population. A lot of those are based on bell curves of what the general population has. And if you're outside of that, that can be concerning when it doesn't even actually signify a true pathology. So the creatinine is an interesting one. That can signify poor filtration in your kidneys. And that's calculated with an EGFR, a glomerular filtration rate. And so that's why a lot of doctors will get worried if you do have a high creatinine. But it's not uncommon for other things to cause a high creatinine. One of the most obvious ones is someone who takes creatine is going to increase your creatinine. So we have lots of patients who take creatine for many of the reasons that you've covered on your podcast before. And so that would just increase your creatinine level and then falsely lower your EGFR. And so a doctor, not knowing that you're on creatinine, may say, okay, you have chronic kidney disease, you need to go see a nephrologist, when in reality it is just due to the supplement that you take. Additionally, if you have a lot of muscle mass, it is a breakdown product of muscle, and so muscle protein, and so that can also increase it. So there are many reasons not to worry, and that's why it's important to have a good discussion with your doctor about it and make sure they're aware that you're on some supplements.
Yeah, and I think it's important when we have this discussion as just a disclaimer and disclosure that that like we're not in any way saying like with some of these that if it's high, you should just like let it go to the wayside because it doesn't matter. We're just saying these are things that are maybe commonly read high and people have questions about, and it might be worth kind of diving into deeper. And I'm sure dehydration can play a role in some of this too, especially when you start looking at like bun levels in the urinalysis and things like that. Like sometimes that can probably play a role. But let's talk about one that was a huge shock to me one time was my CK levels. I think the first time that I ever really got blood work after like training hard and after like a long run, and I didn't really think about it, and my CK levels were like well into the thousands, and it was like alarm. Can you describe what can cause that, what creatine kinase is, and why that's not always a concern, especially in someone that's very active?
Yeah, it's not uncommon for CK to be elevated after an intense exercise bout of high intensity exercise or long duration exercise, a marathon or something like that. Even some sauna use can really increase CK. And it's kind of similar to creatinine. It's a breakdown product of muscle protein, and it's concerning, or we're worried about it because it could signify rhabdomyolysis, which can hurt your kidneys and ultimately cause toxicity in your blood. But assuming you don't have discolored urine, a high CK after an intense exercise bout is normal.
After today's video, I put a link down below for LMNT electrolytes. They are not sweetened with erythritol. LMNT electrolytes are 1,000 milligrams sodium, 200 milligrams potassium, and 60 milligrams magnesium, but that link down below gets you a free sample variety pack with any purchase of LMNT electrolytes. So whether you purchase their sparkling, whether you purchase their stick packs, or whatever, you get a free sample variety pack, and that's exclusively using my link down below. That is drinklmnt.com/Thomas. Again, drinklmnt.com/Thomas. Really interesting stuff. They curb my appetite entirely, but I also have them in a fasted state, and I sip on them during my fasted workouts because I feel like I actually get replenished, but I also get my cravings satisfied. So that link is down below in the description.
At what number do you start really getting concerned with rhabdo?
We get concerned above anything above 1,000, we're certainly going to be asking about symptoms. But assuming that you don't have symptoms, don't have discolored urine, we call it Coca-Cola colored urine, don't have severe diffuse muscle pain outside of delayed onset muscle soreness, it's not concerning.
What is actually happening in the muscle during rhabdo? Because like obviously you have this high degree of CK, and then you get the brownish colored urine. But a lot of times, and I've had rhabdo before, but you're seized, right? My rhabdo case ended up only at urgent care. Fortunately, it didn't end up in inpatient, but it was to the point where I was still functioning. But my sister, training for Ironmans and stuff, has had it multiple times where she's brought into inpatient. for one, I don't want to derail this with the rhabdo discussion, but I think there's a genetic component to rhabdo for sure. But like, what is happening at the muscular level to like, it almost like some of these, like you get basically so sore you can't move at all.
Yeah, I actually can't remember the specifics on the pathophysiology of rhabdomyolysis. I know part of it is due to an acid buildup in the muscles and not being able to flush that out, and that can cause the inability to move. And that's partially what hurts your kidneys, which is causing the urinary effects.
Yeah, that would make sense. Yeah, you're trying to just eliminate this stuff. Another one that's, I think, commonly high, and I'll let you kind of talk about other ones that you see that are commonly high, is high cardiac CRP after hard workouts or maybe even post-viral, things like that. That was a shocker to me one time. Like I always have almost undetectable CRP, and then one time post-viral, I was like a 12, and I actually, Kyle's my doctor, and I called him and I was like, dude, what's going on? Like, and he's like, not too surprising given you did like a 7-mile run that morning and but that is one that sometimes in healthy people can alarm people, because CRP we see as like, okay, this is your systemic marker of inflammation in a way. That can happen like post-exercise, post-viral, other kind of situations, right?
Absolutely, yeah. That's one of the issues with some of these inflammatory markers. Actually, maybe all the inflammatory markers is that they aren't super specific, and so hsCRP is commonly associated with inflammation inside the endothelium, inside the arteries themselves, and so that's why we don't want it to be consistently high. It can be chronically high for other reasons. Too much fat mass can also cause it, but it also can increase from any sort of acute phase inflammation. So even if you roll your ankle, you can have an increase in your hsCRP. Certainly, intense bouts of exercise can increase it, but it's not uncommon for hsCRP or other inflammatory markers like ferritin or homocysteine to be elevated due to things not directly related to a pathology that they're commonly associated with.
Well, what are some other ones that people commonly read high or commonly even read low? But I think high is, for some reason, like I think when people see their lab tests and they see something low, it doesn't psychologically alarm them as much when they see something high. So focusing on the ones that are commonly high. What are some other ones that I don't want to say misread, but are misinterpreted when they're in isolation?
Yeah, I mean, I think that's an astute point that people get a little more worried when they're high, but I think both false positives and the false negatives are equally as dangerous. So I guess I'll touch on another maybe false positive is maybe a high iron, a high serum iron. The iron is very dynamic based on what you're eating, and so if you're eating a steak or some leafy greens the night before taking a blood test, it's not uncommon to have an elevated iron. But in the same way, it's not uncommon for somebody to have true iron deficiency and their serum iron to be totally fine, be at 100 or something like that. And there's other lab markers that are helpful to kind of keep into context to understand an iron, which is why we usually get an iron panel with a transferrin and a percent saturation and a ferritin. And an astute clinician would be looking at a hemoglobin as well. And so there's you kind of look at the constellation of somebody's labs to truly understand what is high, what is low, understand their medical history, what kind of medications or supplements they're taking, their diet, stuff like that.
What are some other things that can cause high or low iron? Because I know, like again, another thing like post-viral, right? Like that can affect iron levels.
Yeah, that can affect iron levels. Your kind of how much elevation you're in can change the iron levels. I guess I'm trying to think through. There's hemochromatosis where you have an iron overload, and so that's a pathology where you really want to catch if you have too much iron. And you may start to see that more in liver function tests, the ALT and AST starting to rise over time.
That's a good one. Let's talk on that for a second, because that's some numbers where that can be really alarming for people. Like, and it's not uncommon to be like just out of range with ALT and AST, which again can be concerning. But it's some of these things where, okay, you may want to look at it over 3, 6, 12 months and kind of see what the trend is.
Yeah, that's one really nice thing about getting consistent labs and not reacting too quickly to some of these that are abnormal. If your liver enzymes jump up, it could be due to some Tylenol use or maybe a GI infection that you had, a viral illness that you just passed and increased your liver enzymes. Maybe a little bit of alcohol use can also increase those. What you really don't want to miss is consistently high liver enzymes or liver enzymes that are uptrending more and more and more. But the liver enzymes themselves being elevated is not so concerning. Even some medications for cholesterol, like statin medications, can increase your liver enzymes. And assuming if that's the only side effect that you're having, and assuming it's just due to that, we're okay with letting that almost get double the higher end of normal for the reference range on the LFTs.
What are some, and I know, you have to tread lightly as a physician, but, what are some things like when they are elevated that you take much more serious, right? Because there's all these things, some of the things we're talking about, not that they're not serious, but you see like mild elevations in them commonly, like in athletes and things like that. Are there any in particular where you see like, okay, if I see this elevated or if a patient sees this elevated, we're getting into more of a range of now people doing their own lab tests, right? They're going to walk-in lab or they're doing this, and they may not always have a supervising physician looking at their labs. So I'm talking specifically to those people. Hopefully people that have an on-it physician are like noticing these things. But there's also a lot of people now that they just order their own lab work. A lot of times, myself included. I mean, Kyle's my doctor, but I do also will occasionally just order my lab work. And then I find myself consulting with Kyle or something. Not everyone has the ability to have that as a resource. So what are some ones that, like, if you do see elevated, really are a little bit more important?
I guess that's kind of a hard question for me to answer because the ones that are jumping to mind are the ones that we just talked about that may show false positives. But those inflammatory markers, I do get concerned about. Whenever I see them high, I want to find out exactly why they're high and pinpoint the cause of that. And if we can't pinpoint the cause of it, we need to check labs again in a little bit and make sure they come down. There's a bunch of reasons, like we already talked about, that could cause those false positives, but we want to be able to explain those. I'm thinking the ferritin and the high sensitivity CRP, the homocysteine we talked about.
What about HbA1c? I mean, that's another one that's kind of a lot of people will trend high on it, or they'll look at HbA1c, or they'll look at their fasting glucose and not their HbA1c. What would you say the importance of someone actually testing their insulin levels are for the average person, or do you think that's muddying the water too much?
No, I think it's helpful and is used in conjunction with the hemoglobin A1C. Generally, the hemoglobin A1C is the amount of sugar your blood has been exposed to over the last 3 months, but that can change depending on how quickly your red blood cells are turning over. And so someone their blood cells are turning over more quickly, that's showing a shorter time period of that. And it's not uncommon for young, healthy people to have a high hemoglobin A1C and that be a kind of a false positive for prediabetes or diabetes. And we can check that with a fructosamine, which is a little more of a sensitive marker for that.
What is fructosamine exactly?
Fructosamine is another enzyme, and I don't know, I can't think of it off the top of my head exactly how it's related, but we use that to confirm either if the hemoglobin A1C is showing a true issue with insulin resistance or a false positive.
Gotcha.
Yeah.
And then, I mean, now we're starting to see more sort of almost AI reading of lab work. And I'm assuming that it's probably using algorithms to look at like other markers and kind of quantify what's happening, or is it looking at multiple lab? You're just seeing more AI kind of coming into this in general, which I think could be promising, for many patients that are kind of doing things themselves or with a little less doctor supervision or just less face-to-face. Are you seeing much of this right now?
Yeah, we are seeing quite a bit of this right now. Going from patients just putting their own labs into ChatGPT or Claude and seeing what it pops out. And that's not so different than just Googling what your labs are. They're just large language models kind of regurgitating the stuff that's out there on the internet. And then on the other end, there's more kind of fine-tuned models where they take those base models and they train them on medical literature, and then they use experts to kind of help define, oh no, we exactly want to say this, and no, I don't agree with this. This is actually the true level. Kind of another helpful use of AI is being able to look at large amounts of data that maybe me as a doctor may miss or not be able to really understand. So really identifying small trends or grouping together labs that take a little more administrative work. So kind of going back to that insulin glucose discussion, we're thinking about hemoglobin A1C. We're trying to diagnose prediabetes and diabetes, but more the underlying process of that, which is insulin resistance. Yeah. But you can define insulin resistance through other markers like a HOMA-IR score, which is taking the glucose and the insulin and kind of looking at that ratio. And if you're over this ratio of 2, then you're much more likely to have insulin resistance and be developing diabetes in the future. So that may get missed on a normal lab panel with your doctor. But some of those yeah, AI is pretty good at kind of picking up those things and kind of outputting it for you when you input it.
Do you think that, I mean, AI has a strong future in terms of sort of lessening the load for physicians, so you're not having just the, so many of these patient visits, although seeing your physician face-to-face is probably a good idea, but there's probably a lot of just minutia in in a standard like family practices daily life, right? If they can potentially, in my opinion, it looks like if they can potentially limit maybe a little less at the top of the funnel, so to speak, by having some done with AI, it allows them to spend more quality time with a patient further down the funnel, so to speak.
That's my reading of it as well. I kind of see AI as, just an additive tool into the tool belt of clinicians, kind of like maybe like imaging studies is another kind of corollary. Like we only had x-rays, and so we had to do a lot of diagnostics based on physical exam. And then when there was MRI and CT and ultrasound, we were better able to visualize the anatomy and identify gallbladder disease or appendicitis more specifically. And so the doctors then spent less time doing that sort of thing and making false positive diagnoses and false negative diagnoses, and could spend more time with the patient, kind of discussing things. So I kind of see AI as doing the same thing, really kind of narrowing the scope of what the doctor has to review, providing the doctor with kind of evidence-based recommendations, and so it can pull literature, and then lightening a lot of the administrative load, which I think is often underappreciated, but is becoming more and more used. A lot of health systems are using AI to generate responses to patient portal messages. So instead of waiting for a week or 2 weeks or 3 weeks for your doctor to respond, this is providing the doctor a kind of a template of how they normally would respond. And the doctor, of course, is still approving that or saying, no, don't actually say that. But then you can get responses much quicker and help people with problems instead of waiting for so long.
Yeah, it's like when you look at AI being used, again, when I say top of funnel, I just mean like kind of those initial like visits, right? There's probably a lot of people that just forego going to the doctor because it's a pain in the butt on that first regular checkup, right? It's like they're just like, forget it, I'm young, I'm healthy, right? So it's like if you have the ability to have almost virtual reads, or like go get your lab test done and have AI interpret it, or go get an MRI and have AI assistant interpreting it and actually flag the physician at that point. So it's like less overall load on the patient, and then if you look at it from the other side, I don't know if you know the numbers specifically, but like what would you say like average patient volume for like an average primary care PCP is on a daily basis? Like how many patients are they typically seeing?
Well, before I came over to Gillette Health, I was seeing 20 patients a day, and we would get at least 20 to 30 messages on top of that per day. And so it was just too much load to actually respond to those people in an in-depth way. And so, this is a great use case for AI to quicken things up and provide higher quality care.
How does that work potentially on the reimbursement system? Like because I remember when I was working in the corporate healthcare side, it was really difficult when the Affordable Care Act came in, because it just like squashed a lot of the reimbursement and basically made it so that the patient volume was significantly more, and it was very difficult for physicians, so much that a lot of them were just either becoming hospitalists, or they were having to go be in or go a fee-for-service route. It was like one of the only ways, which was making it not affordable for the patient, right? So it was really difficult time that I don't think people understand. Like 2014, 2015 was a really tough time to be, especially in private practice. And a lot of the blame gets pushed on the doctors, and the doctors just had a lot of volume coming in. This gets into a little bit more, I guess, an advanced administrative question, but is insurance going to reimburse? Is the physician still going to make money? Is it going to be actually incentivized for a patient or for a physician to use AI in such a way to achieve a diagnosis and ultimately bring them through the filter to have a better patient outcome, if that makes sense?
Yes, that makes sense. That's how it's being marketed right now and being kind of sold. We'll see, I guess, if that turns out. It does seem to, some of the AI applications seem to improve the efficacy of the clinicians, and so they're spending less time kind of outside working hours. However, the kind of the surveys of doctors is pretty mixed. It's kind of unclear how much they actually like it. There's a preprint paper at UCLA right now that it saved a lot of time, maybe 15 minutes per day per doctor, which is a significant amount. But then they stopped using it after 3 months. So there's, I think, more to unpack there. I think we need to kind of find really good, clear use cases for it, and then use them for that.
Especially over like I could see it being really useful with long-term patient data. Like, I mean, you think about like how big a chart can be over the years, and sometimes it's unrealistic expectations on a physician from a patient where not morally and ethically, the physicians are usually have their hearts 100% in the right place. And it's one of these things where it's like the patient is able to keep track of their life, of course, legitimately easier than the physician is able to keep track of that patient's life. I mean, that patient is living that life. And you're going into the doctor's office and don't you remember that I came in here 4 years ago with this? And the doctor's like, okay, let me look at your chart. I mean, if there can be an AI read that happens before the patient visit, imagine, and the physician has a summary with these flags and they've seen these trajectories. I could see how the outcome could be really great, but I could also see how it's decreasing patient visits in a way and actually could have a decline in reimbursement, which would de-incentivize physicians from using it.
Yeah, I think there may be kind of a long-term tail to your earlier example of the insurance then ultimately leading to more volume. I think it may change things in the long run, but as of right now, it seems promising that it can help with those use cases. And I get it from the patient side as well. If you've talked to this doctor, you've filled out multiple of these pre-visit questionnaires and answered it, I understand that it is frustrating too to answer these things multiple times. Yeah. But it does take a lot of time to go back and review those things, and sometimes it is easier to just ask the person themselves.
What's your take from like even the liability standpoint as AI gets involved with prescriptions and things like that? When you're being like, how much of physician time is spent just kind of refilling a prescription or reevaluating a prescription need. I could see in the pros and the cons of this personally. I could say, okay, this could streamline just the prescription process and streamline where there's actually the pharmaceutical companies actually probably like it because it's just streamlining efficiency and refills and streamlining a lot of these things where it's easier to just prescribe based on like AI. Are we going to get to a point where AI could actually form a diagnosis that could go directly to a pharmacy and ultimately prescribe, or do you think there's always going to be like a physician oversight over that? That's and where that could go wrong, right? You can see the pros and the cons of that.
Yeah, I mean, I think there is a lot of time spent in that way that truly isn't clinical knowledge. You're not really helping the patient so much. It is just making sure they're getting the right dose and clicking some buttons. And so I think AI is going to help immensely with that. Ultimately, though, someone needs to be responsible for that medication. If there's any problems with that medication, someone needs to be on the hook for that. And that's, as of right now, that's the doctor. Even if they're using AI tools, the doctor's responsible. And so there's very little appetite from the clinical side to completely adopt a model where that's all AI doing that themselves. One really cool kind of use case for this is getting prior authorizations, or I guess even before that is just finding medications that are part of the formulary. It's not uncommon to prescribe a medication for somebody and it was covered for the last person, but due to their insurance model or just their the plan that they're on, that medication is not covered and it's an exorbitant price. And if they just switch to a different medication, it would be less of a price. But that we're kind of blinded to that on the prescribing side. You have to pull up this health insurance plan and look through this Excel sheet and then find what is covered. And that changes all the time. So you can't even kind of save those things and adopt them. But AI is able to do that and save a lot of time.
That's a good point. I've run into that a lot, like with you just, certain inhalers or certain things like you require this prior auth and they're trying to catch the doctor and they're, or an NP or get some kind of, and then you're like, okay, I can't get my script. I got to go back a week later. And it's like, it's a burden on everybody's shoulders.
Yeah, it takes a lot of time. And the prior auths, it's not uncommon for me to spend an hour on the phone just waiting to get a hold of somebody. And that's just the time I could be talking to patients, responding to messages, doing things that actually benefit people. So, and the insurance things are limited because there's requirements and you need to meet these certain requirements. And that's a great use case for AI to know exactly what those requirements are, make sure that they're in the note and well documented, and then send that to the insurance company. There's a kind of funny future, though, where the insurance companies are also using AI, and it's just these AIs going back and forth about medications. We have humans doing that right now, but that could be the future.
That's interesting. Yeah, you get into this like endless loop of going back and forth on that.
Yeah.
But it's fascinating, and I do think that from a diagnostic perspective, like it's nice for if a patient walks in and they've got an ailment, and you can put something into a system and it cross-references with what's in their chart and it says, hey, like recommended MRI for this, and maybe that's just not something you thought of, right? It's like I think sometimes there's too much. I think for me, coming from the like the healthcare administrative side, predominantly in long-term acute care, like it was just like I see the pressure that's put on physicians, and I don't think a lot of times patients see that, like the pressure that's put on physicians to like make the right choice or do the right imaging or do this and that. And it's not the physician's fault. It's just like the patient volume, the overload. It's really difficult. So I've seen a lot of things on the internet, people like really up in arms and concerned about AI in healthcare. And I think when used properly, I think this can really allow physicians to do probably what they went to med school originally to do.
That's the best case scenario, that it turns out to do that, and it alleviates a lot of the administrative work and allows physicians to spend more one-on-one time with people. I mean, one common complaint is that the doctor spends the whole encounter with their head in the computer, not even really looking at you, because of all these other requirements, these administrative requirements. And so this AI could help with that. And then it could help, as you point out, kind of identify things that the doctor may not be thinking about. Even there's a type of AI model called a clustering model, and it can find different lab markers that are maybe the doctor wouldn't put together, but identify, okay, this is kind of phenotypically what other diabetic patients look like. So you should think about checking the hemoglobin A1C and the HOMA-IR when that might not have come up to the clinician.
Yeah. I mean, eventually think where that could go with even cancer risk and all kinds of things. There's things that maybe just aren't in our scope of awareness yet, because it's like there's so much data, right? So much. And now you can look at large collective bodies of data like we couldn't even do 5 years ago, and probably start making some real interesting links, or even, hypotheses that can lead to at least additional imaging, additional testing.
Yeah, exactly. We have some really cool patients at Gillette Health who are biohackers, and so they have huge Excel sheets with tons and tons of data from years and years back, every single lab and depression screening and sexual function and all this stuff that's hard for me to really go through and wrap my head around, but we can use AI and plug that into an AI, a HIPAA-protected AI, that can pop out like, oh, during this time after he started this medication, he noticed a significant improvement in his anxiety. And we might miss that as clinicians.
Yeah, especially these subjective scores that like patients are keeping track of, which is really cool.
Yeah, and so it empowers the patients who are kind of keeping track of their own data, and kind of helps increase the quality of the care that the doctor's providing.
No, I'm with you on that. Well, man, where can everyone find you? And I know you've got like some cool AI doctor stuff that you guys are working on as well, Gillette Health. So where can everyone find you? Where can everyone kind of look into that a little bit?
Yeah, I'm on Instagram, taylormartin.do.mph. And I'm a preventive medicine doctor at Gillette Health, so anyone can come see us over there. And we're putting together a lab visualization tool called Sage Bio, and you can upload labs from anywhere. You can upload them from your primary care, your concierge doctor, the ER visit that you went to in a different state, all in one spot, and trend those over time and get some AI insights into that.
Right on, man. Well, thanks, brother.
Yeah, thanks for having me.